Thank you very much. As you can see, I will try to say something about research ethics post-Macchiarini. But first, just some notes about myself. I have a background in moral philosophy. I'm a professor in medical ethics at KI since 2015. I've been here for more than 10 years, actually. I teach research ethics at all levels, from basic education to doctoral students and even to doctoral supervisors. I also have research ethics as my main research interest. And I started out by doing some work related to biobank-based research. So that was my origin when it comes to medical ethics. And I dealt with things like informed consent, autonomy, that kind of issues. But in later years, partly because we're teaching so much on research ethics, I've also become interested in scientific misconduct, ethical issues around that. And write a bit about that. I've written about plagiarism, authorship issues, and one of the more recent papers was about rogue publishers, predatory publishers. The reason why I chose Macchiarini case, apart from the fact that it's recent and it was here, I also think it's interesting because it brings up many issues and not necessarily only those that people yell most loudly about, but there are many others. Of course, a patient safety issue is one, the formal approvals, scientific misconduct in published papers, responsibility and accountability of collaborators, routines for examining scientific misconduct at KI and also in Sweden, explanations to why this happened. I'm sure that you are aware that as the scandal developed, you could hear very many people with their own personal agendas taking the opportunity to bring that up as the Macchiarini case exploded. Then, of course, also the issue of prevention of this. So there are many things to look at. And one thing one could ask oneself is, of course, whose problem is this, or whose problems are they? And to me, it's obvious that some issues clearly belong to the hospital side. Patient safety cannot be a university issue. So it's patient safety and also related procedural issues that I think were interesting. For instance, how did they make the decisions? What were the procedures around that? And also about formal approvals for treatment, also an hospital issue. So you could say that the fact that Macchiarini and colleagues could do these operations, that was clearly responsibility of the Karolinska hospital and not KI. But then I think that problems with these matters may still be explained to some extent of how clinical research is done in Sweden. That you have typically the healthcare provider who is also the researcher. That is not ideal. I guess it's for very pragmatic matters, namely that if you are the treating physician or a nurse, you have access to the patients. Anyway, healthcare system needs to be clearer about the liberties and restrictions for clinicians acting as researchers. And here, of course, KI can join in the discussion. But it's not that we are without issues of our own. And there are many practical things if you look at forward. Investigations into misconduct. I just saw on my ride here just a short while ago that now there is a new suggestion for new regulation. It's out, I think it's out today, about how investigations into misconduct will be carried out in the future. It's just a suggestion at this point. Responses to scientific misconduct are, I mean, if you note that you have investigated, what should you do then? Then, of course, punishment will be one issue. And again, I think they will have ideas about how that will be handled in this investigation. But until it's in place, it's still the thing for KI and for other universities to decide what to do once they have noted that it is a case of misconduct. And one of these things is the retraction of papers. And I know that there has been criticism in the past that even though there has been decisions made that a paper is fraudulent, sometimes nothing seems to happen to the paper, it doesn't get retracted, and that's also problematic. And here you could wish that KI would have a clearer policy in the future, and I think we should have a national policy for how universities should handle these issues. And then we have all the prevention issues, formal control. I think that's where KI started. Looking into CVs a little bit better, looking at spare time occupation for researchers who are employed here. Education, promoting research ethical reflection. Social control, that is something that must take place to begin with in the research group and up. You have the question of values. And I think for both these things, social control and values, it's very difficult to make things change. So the practical issue for all of us is how to influence attitudes to have a change there. And then, of course, touching this is the question of incentives, monetary, career-related, where I usually say when I teach that many of the incentives that the researchers have pull in the wrong direction if you want them to be fully honest with what they're doing. So these are some issues. And I don't claim to have a solution for all these difficult issues, especially not the organizational ones. But I think I could still say that we need to recognize that the problem is broader than a single researcher or a research group issue. So it's not just a matter of identifying the bad apples. I also think that we cannot expect to put an end to scientific fraud. We can try to change incentives, we could try to change the research culture to make it less tempting to be fraudulent in the future. That's what's reasonable to expect. And when we're doing this, we must not build systems that are fully directed at identifying bad apples, because I think the cost to research, if we do this too thoroughly, will be very great. Maybe so great that it doesn't become particularly interesting to do research anymore. So it's a sensitive balance here on how much effort to put into chasing individuals and to what extent we should look at the research culture at KI instead. As I hinted, I'm not very good at organizational change. Medical ethicists aren't. But I think there are other things that we can contribute with. And I have identified a number of issues that I think are really important, that have sort of turned up during the Macchiarini case, and where I think we can actually make a contribution with a background in moral philosophy. And one of those is provide analytical tools for dealing with scientific misconduct. And that's a Swedish problem, but I think it's an international problem as well. We can examine the relevance of the research therapy distinction, that is the distinction between what is healthcare, what is research. We can also examine the responsibility of co-authors of scientific papers. And since we are actually doing empirical work, one of the things we could do and are doing is investigate attitudes and experiences among researchers, doctoral students and medical students regarding different kinds of scientific misconduct. And I will say a little bit more about the first 3 points here. I think what you can see from international guidelines, governmental agencies, is that they seem to be very complacent to equate scientific misconduct with fabrication, falsification, and plagiarism. And that seems to be the idea of this Swedish investigation that is presented today, I think. They again say, this is what we are going to look at. And if you're happy with that, that means that you're quite happy to deal with only one level of scientific misconduct. And I think that is a mistake. If you're looking at differences between what researchers who deviate from good research practice do, you can see that it's not reasonable to just have one level. I mean, consider the case at the bottom here, where plagiarizing a fifth of a page of introductory text. I mean, that's not good. It's not accepted with present standards, but it seems to me to be on a very different level from plagiarizing research results, which would actually amount to fabrication, if you think closer about that. So if you stick with FFP, you will have the problem of trying to cover a couple of sentences of copying and pasting and really serious research fraud. Bouter and his colleagues suggested last year that we should give various weights to offenses based on their influence on science. Well, how bad does it affect science? The worse, the stricter we should be about it. And a colleague from Uppsala, Stefan Eriksson, and I have suggested the use of 3 different levels. I think the paper is not out yet, but it will be soon. So we suggest that the lowest level would be avvikelse från god forskningssed, deviation from good research practice. The mid-level would be oredlighet i forskning, that's what's used now. Scientific misconduct in English. Grov oredlighet i forskning as the most serious one, serious scientific misconduct. And here the idea is that the lowest level, deviation from good research practice, that would be to not follow widely accepted norms of how researchers should maintain their integrity and the integrity of research participants. So it could be things like faulty data handling, skewed referencing, minor plagiarism. It's not acceptable, but it's not very serious comparing to many other things that can come up. And then as a mid-level, scientific misconduct, where the idea is that either you intentionally or out of recklessness perform or present research in a false or misleading way. And that would cover these FFP, fabrication, falsification, plagiarism. It will cover, I think, other ways of being misleading in your publications. And then as a most serious category, serious scientific misconduct, where you could think that it might be appropriate with more severe punishments, even imprisonment perhaps at the gravest, where you would have particularly severe cases of misconduct, and where the idea, I think, should be that it should be intentional, if you should, that you're intentionally misleading and not just reckless. It could be serious misuse of one's position causing serious harm. I would say that in the paper we write, we are not much clearer about the different levels than my presentation now, so you can see that there's a lot of work on the details that needs to be done, but I think it's a reasonable approach to find 3 different levels from one more lightweight and 2 more serious ones. And we suggest in the paper, just as it seems that this investigation suggested today, that there should be a new dedicated authority, ny myndighet. And what we suggest is it should investigate scientific misconduct and relieve universities from that burden, which I think is a good thing. It should sentence guilty researchers, but apart from chasing them down and punishing them, there should be a function of support to help with improving the research environments. It seems to me that what they are suggesting now today in the investigation is that they will actually say something not only about the case but about the research environment, but that would just be another no-no from the authority. You shouldn't do this, you should be compelled to make these changes. But we think you need some kind of support in this work from this authority. I think that the Macchiarini case certainly gives fuel to the argument that the present system doesn't work. It lacks independence. Vested interest may affect the outcome. Some suspect that there were vested interests. That's why KI didn't say that Macchiarini and his colleagues were guilty to begin with. But note that even if the decision of the former vice chancellor was correct, with this system you still have the suspicion that it wasn't. You still have the suspicion that there were vested interests. So I think there is a risk of lack of trust also when the cases are handled properly with the system we have now. So therefore we need something else. So this is one area where I think we can contribute with how to investigate, how to say how serious things are. Another area that turned out to be relevant in the Macchiarini case was the research therapy distinction. This is not a new issue in medical ethics, but it turned out to be important here. Namely, the question, is this research or is it examination treatment? There was a great point made about that distinction when they talked about whether there should be ethics applications or not, for instance. But I think the big issue is not whether you can make a distinction, but the interesting thing is whether you should give that distinction an ethical role. And if so, what role should that be? And so those who defend the distinction between research and therapy, they do that mainly, I would say, to protect research interests from treatment interests. That the treatment interest shouldn't just eat up all the research resources. While those who criticize the distinction, they first want to stress that patients should always have first priority, so you shouldn't make this distinction when you can say patients. And they also have the argument that research nowadays is entirely entangled in clinical practice. So in practice, you cannot make the distinction. That has been the argument. And I think when it comes to making the distinction, I think those who say you can't do it, they are obviously wrong. Research means one thing, therapy another. Therapy is for the present individual, research for generalizable knowledge. And just to give an example in both directions here, that being examined or getting therapy does not necessarily involve participation in research. I mean, when you think about it, it's really obvious. And you can treat an infection without getting included in a research project. I mean, that happens most of the time that you don't get included. And also, you can be involved in research without being treated at the same time. If you're interviewed, it's not that they're trying to treat you at the same time. So it's very obvious that for some cases, it's very easy to make the distinction. But more interesting is, of course, when research is happening in the treatment context. And my view on this is that even when actions are part of therapy and research at the same time, you can still say what things are done for the sake of research and what things are done for the sake of treatment. And I have some examples on this. For instance, when you do randomized clinical trials, the medication is not individually adjusted, but according to protocol. Why? Well, because it's research. If it wasn't research, you would, as times went on, adjust the treatment to what worked for the patient. If you think about retrospective studies on available data, then it's very easy to see what's research done for research or not. Namely, everything that's done at the time is done for research because the patients were already treated. And when you're looking at prospective studies, the patient is treated now, but it seems to me that the research activities are mainly parallel and easy to distinguish. It's still the case you can say, yeah, we're doing this because we're doing research, otherwise we wouldn't do it. And when it comes to preparation for future research, I also think that the actions are identifiable. For instance, that you are collecting an additional test tube of blood. Maybe you couldn't say, if you take 3, you couldn't say which one is for research, but you could say that nowadays we take 3, before we took only 2. I mean, so you can still say that you can identify what's done for research. When it comes to data collection for quality assessment and development in healthcare, then I would say it's not particularly easy to distinguish that from research. But on the other hand, it's very easy to distinguish that from therapy. Because if you do follow up for quality assessment, that is a kind of research. If you're trying to publish it, the ethical review boards would say it's research. And there has been the idea that there is a potential exception, namely frontline novel treatment, exactly the Macchiarini situation, a last resort for the patient. Maybe that wasn't Macchiarini, I'm not sure about that. But anyway, the frontline novel treatment. And here you have a situation where the intention to treat and to do research is present at the same time. And there is no disagreement about what should be done. You're doing as research exactly that which you're doing as treatment, but that is really because you don't have a research protocol. So you don't have any fixed ideas about how to do this. You're simply following what the treatment is doing and noting that. So it's just follow-up. And then that's when you have but I think that also here it's possible to identify what's done for research and development and what is done for the sake of therapy. And furthermore, even if it isn't, it doesn't make that much difference. It's not these cases that are the most controversial. Let me get back to this. That it's permitted in the case of Macchiarini was, of course, extremely controversial, but that was a healthcare issue, as I said before. So why should we care? Well, the fuss about this is, of course, about normative issues, not about definitions. There are special obligations stemming from research regulations. So if you're doing research, you have to follow these and these rules. If you're treating patients, you have to follow these and these other rules. So therefore, of course, it's interesting to say, okay, what should we call it? Is this research? Is it treatment? Is it both research and treatment? It matters for what regulations will apply. And I would say that the distinction is normally important in relation to specific issues where research and therapy are actually easy to distinguish, but there is a clear conflict of interest which makes it interesting in practice. And one clear case of this, I think, is early stopping of clinical trials. When you stop the clinical trial early because it seems to be so successful, not because it seems to be dangerous, but because it seems to be so successful, and so you want to stop it early to make it accessible also to those in the control group. And that is a clear case where you have a conflict. The treatment interest is to stop it now, give the drug to everyone. The research interest is, of course, to continue with the study, to get the follow-up time that you planned to begin with. And if it's stopping really early, it could be that you haven't even performed the period where you would actually distribute the drug. So this is one situation where those who want to defend the distinction is to say we need to protect research from being stopped because it looks promising. We need to know that it's promising before we bring it in full scale into healthcare. But there is also actually another reason to care about the distinction, and that is for the protection of patients. It's important when researchers blur the distinction when they want to do research while pretending to the patient that it's only therapy. So you actually have that as another reason to be in favor of making the distinction and making it important. Then saying that the distinction is maintainable, that there is no reason to blur it, that's one thing. But then, of course, you could still say that there may be situations where policies shouldn't rest on the distinction. And I have two cases in mind. One is the situation where the patients, concerned individuals, do not perceive the difference. So the patients that research want to include in research, they don't see the difference between research and therapy. And that seems to be quite common. They think that now the doctor said I should do this, it's just to make me more healthy, but they were actually included in a study and they perhaps don't know if they will be any better. So when information efforts don't help, one should perhaps apply both sets of requirements and perhaps apply the stricter one if they conflict to protect patients. I also think that for new forms of treatment, when there is considerable risk involved, it may be the best policy to treat it as therapy and research at the same time and then apply both regulations. And this is, of course, where you can see that one of the mistakes around the Macchiarini case is they seem to have spent quite some time trying to figure out, is this really research or not? Do we really need the application? Let's phone around and ask. Maybe a much better approach would have been to say, let's treat it as research. And if it's research, then we need the ethics application. Okay, my final area that I think where we can make a difference in medical ethics is to explore the responsibility of co-authors. And this was also very tightly tied to the Macchiarini case because the Central Ethical Review Board in Sweden, they are examining papers now. And they have, as far as I know, made a decision on 2 papers, maybe more. But the 2 I know of, they said they were both fraudulent. But that was not the only decision, their recommendation. They also said that all authors should be held responsible for the misconduct. And there was quite a span of those who were leading the project and some doctoral students who had made some laboratory stuff that was relevant, but they were not very involved in the rest of it. Here, KI actually took quite some time to decide. I think they thought it was difficult to say no again to someone external, but they actually didn't follow the recommendation. They said that only the central researchers are responsible. So that was their response to the responsibility issue. And we can ask, of course, what's the correct view and why? And one of the things one has to think about here is the difference between being responsible and being held responsible. How should they relate? Should you hold people responsible, that is blameworthy, deserving punishment, etc., who are not, in a sense, who were not involved in the actions? If you say everyone should be considered guilty, then you're saying that being held responsible and being responsible should be considered as the same. We have started working a little bit on this. So a preliminary view is that co-authors on scientific papers should not be held responsible for scientific misconduct unless they were personally involved in the actions constituting misconduct, encouraged misconduct, or knew about or suspected it without taking appropriate action. So if you defend this, then you would say that responsibility for research misconduct must be on par with the responsibility assumed for other wrongdoings. There must be intention or recklessness to establish guilt. I think it will be legally difficult to claim something else in Sweden and many other countries also. So the conclusion there would be that not everyone should be held responsible for everything, but some journals, some guidelines say that, well, at least someone should be held responsible for what everyone else does. Some journals call this the guarantor of the paper. BMJ does this, for instance. Is this reasonable to have someone that should be responsible for everything? And then I would say, well, it depends what you mean. Someone, at least one person, would have to know why we have this collaboration. What are the different people providing for us to succeed in writing this interesting paper? So in that sense, of course, but to be responsible for what everyone else is doing if some of them are doing something fraudulent, that I think is another thing, and I think the response to that should be the same as for all the other authors. You have to be involved or reckless in some sense for it to be reasonable that you should have this responsibility. This doesn't mean that some people have more responsibility than others. So sort of leading the project, they have to assume more responsibility than others. But exactly what responsibility is worth discussing more? I mean, what responsibility should supervisors have, for instance, for what their doctoral students do? How much should you have to check up on what they're doing? So you can say afterwards, well, I did enough, even though I didn't find out. It could be helpful to have this formalized and stated beforehand, I think, if it's possible to say it in some useful way. So in summary, I think the Macchiarini case has brought up many ethical issues. Some of these are more an organizational kind, and I hope that others are better at doing something about those. But I think medical ethics can help with others, such as providing tools for investigating scientific misconduct, exploring the research therapy distinction normatively, and examining responsibility of co-authors of fraudulent papers, and providing empirical input regarding attitudes to misconduct, which is important if you want to change the attitudes, change the values at KI. Thank you very much.